Welcome to Stress and Shock. This is a audio lecture that I started last semester. One of the things that I found with shock that it's so easy well, it's not so easy, but looking it on paper and in the book is so different from what you see out with the patient. Or it's hard sometimes to correlate the book to the patient. So one of the things that I noticed when I was talking to students in the past was this was one of those lectures that was difficult for them. And so what I did last semester is I did a audio PowerPoint where you would go through my lecture and all the different stages of shock. Also there's part on stress here as well, but it's shock that predominantly was the problem. And you can look at this lecture, listen to it, take your time, kind of get it all together. And then what we'll do is we'll come in groups into the simulation lab, and we will go through these stages with the mannequin. Now, of course, the mannequin doesn't replicate the hospital environment exactly like I would like it to, but I think, and I know that last semester it was much better to go this route. So I'm always eager to hear your input, and I'm always eager to make revisions. And so I'm hopeful, though, that you'll find this to be a useful one for you, especially as you work with these patients out on the floor. So let's get going. Stress. Well, what is the importance of this to us as nurses? Well, statistically, 75 to 80% of all physician visits are stress-related ailments and complaints. So it is important to us because stress does impact our health. Stress is linked to the 6 leading causes of death. So we know that this is important, and certainly as you guys have moved through nursing school, you definitely understand the effect of stress on our bodies and our minds. So one of the other things that we need to do as nurses, besides realizing the importance of it, is we need to recognize the signs and symptoms, and we'll talk about those. And we need to know how to intervene effectively. What kind of stress management techniques can we recommend to our patients and to our families and to ourselves to help ourselves deal with stress? So let's look at the effect of stress. Now, the reality is that it affects individuals differently as far as on a cognitive and a behavioral sort of way. Physically, though, and when we look at the effect on the parasympathetic and sympathetic systems, it pretty much affects us all the same way, some of us more intensely and some of us not as intensely. But for some people, there are positive outcomes from having stress. It helps them, it stimulates them to think more, it pushes them to have mastery. I know that Group B probably definitely feels this way as I push you to become more and more masters of your clinical environment. And it is stressful. And, you know, it's much more easy to just kind of sit back and let it be and not push yourselves. I mean, life is grand, isn't it? We all have a really nice day, but the reality is that when you graduate from nursing school, you're not prepared for the stresses that you'll have then, and it'll be even more overwhelming. So I push you for mastery, so hopefully that is one of the positive outcomes of stress. And it also causes you to be more alert to your environment, and that's a very good thing. Negative outcomes can be certainly where we get overwhelmed. It overwhelms our coping mechanisms, and our ability to handle what's happening to us just overwhelms us. And then sometimes as a result of that being overwhelmed, we end up removing ourselves from the situation. We stagnate. We move ourselves away. And I definitely can bring my husband up as one of those sorts of people. When he gets overwhelmed by stress, he just removes himself from the situation. Sometimes that's a good thing, you know, but sometimes that's a bad thing because then we can end up stagnating. And I'm sure you can think of somebody in your life, perhaps yourself, a situation that you've had that you've reacted by just removing yourself and not pushing yourself. And like I said, sometimes that's good and sometimes that's bad. Now let's look at the physiological changes that can occur. Now remember, our body cannot really discern whether the stress we're having is good stress or bad stress, whether it's going to cause us to have a good outcome or a bad outcome. Our body just knows that it is being affected by stress. So we're going to first look at some of the sympathetic nervous system responses, and I'm certainly making this very simplistic, but I'm just basically trying to key you in on the important things that you need to focus on so that you can take care of yourself and others. So with the sympathetic nervous system, it responds to a stressor. And what ends up happening is it triggers that fight or flight response that we have talked about so many times through all the different science classes that you've had and fundamentals. So when that fight or flight response is triggered, we are going to see the heart rate increase. We're going to see our bodies diverting blood from unimportant, insignificant areas of our body to the vital areas. And so then that's going to end up with our blood pressure increasing, our respiratory rate increasing, and as a result of cortisol being put in our body, or what's the right word to say that? Having more cortisol available due to the stress, we will also have our blood sugar increase. See, I still kind of garble all my words, even on an audio. You would think I wouldn't, but I do. Okay, the thing that we need to realize is that these biochemical changes can have long-term bad effects. Cortisol binds to its specialized neural receptors, and I don't think I have any test questions on this. This is just general information so you understand how damaging cortisol can be. What it'll do, it'll bind to the specialized neural receptors. That then results in decreased communication between the synapses. So what ends up happening is our synapses don't work as well, and also more plaque develops. And so what ends up happening is we end up with more neurodegeneration. And this will impede the recovery of some of your brain cells. And so we can stop this, though. The good news is we can stop this or slow it down by just changing our lifestyle. And that means exercise will help us to stop this. Meditation is another one, as well as sleep is another very important lifestyle change that can help us with this. Some of the things that we need to worry about is that it can push the people that are at risk. People that are at risk for having cognitive delays, having memory issues. So if you add this stress on top of them, that is going to make it very difficult for them. And a really good example that I see is with my father-in-law, who has a very mild form of Alzheimer's. Well, I don't live with him, so I call it mild, but it can really be a problem when he is stressed. When he gets stressed, and especially when my mother-in-law has any kind of health issues or there's any problems going on in the family, my father-in-law, it really will put him for a loop and will really decrease his ability to remember things, his ability to react the way he normally would. And so it's really important for not decreasing the amount of stress around him. Certainly, they have shown also in the literature that cortisol increases everyone's risk for Alzheimer's and Parkinson's because of this neurodegeneration that can occur. So even though I'm not going to have any real questions about this, we really need to remember that stress is not something that we want to try and help our patients and ourselves with. And remember that almost every system of our body can be affected. Oh, and there I went. The next page had all that stuff. I wondered if it did. Well, there it is, going over the cortisol, the effect on neurodegeneration, the lifestyle changes that we want to do, such as exercise, meditation, and sleep, and the people that are at risk and what kind of risks we are for is Alzheimer's and Parkinson's, so we can really diminish those by controlling the amount of stress that we have in our lives. Yeah, I say this as you're all in nursing school. Sorry. Okay, so here's one of my little diagrams showing some of the indicators of stress. Now, some of the things that we're going to see here, some are cognitive indicators, some are psychological indicators, and some are behavioral. Not all of us react to stress in exactly the same way. Now, going down here, neuro, the pupils dilate. That's a sympathetic, neurosympathetic, CNS sort of reaction. So that is one that's going to probably happen for all of us. It helps us with that fight and flight. Headaches, though, that could be a result of the muscle tension that occurs there. And that might not occur to everyone. Our immune system, they have shown, is affected by the fight and flight because we do end up with delayed healing. There is a cancer link that they've seen with stress. Integumentary, we can see some urticaria, acne, hair loss, eczema. That's all individual, not necessarily the part of the fight and flight. So you can look through all these things and see some general things, but I'd say if I was to go down through each one, some of the things to remember is, yes, our pupils will dilate. We may delay our immune or impact our immune system. Palpitations, increased heart rate. Going down here, we will have our bowels do slow down. For some people, they'll end up getting colitis, but the GI tract definitely tries to slow down during the beginning of fight and flight. It's only when we have chronic stress that it changes. Our urine output does stop with might slow down with fight and flight, but that is not true as we have chronic. Some people get urgency when they're very stressed. And of course, muscle tension is just part of that fight and flight. We're prepared to fight or run. So, what is our role as a nurse? Well, first off, what are our goals? Our major goal is to have safety. First priority, safety. We want to make sure that ourselves and our patients and the people that we are dealing with are safe. Is there any risk of harm to themselves? Is there any risk that the stress they're under will impact and they will harm someone else? So that would be your first priority. The next priority is to try and lower that stressful situation. Try and make it a better situation. And maybe the way that we can do that is by increasing their resistance to the stress. And so we're going to help them learn tools to try and minimize the harmful effect of stress. Another thing that we need to know as nurses is the neurophysiological changes that occur. And that's basically what we are just looking at under the sympathetic nervous system and the effect on all the different systems of our body. Another thing that we need to do is be a patient advocate. And a patient advocate needs to use effective communication. And this is certainly something that life and time gives us increased abilities to have. And that's where some of you that are older nurses can really bring your life experiences into the situation and be able to communicate effectively. But it is something that you have to learn, and sometimes it's a trial and error situation, but I think listening to other nurses and how they communicate effectively is things that you want to take away and utilize in your own practice. Okay, another nurse's role is to assess. We need to, first off, rule out any medical problems as the underlying stressors. There are some things that can make us think that they're under stress, but in reality, they're having hypoxia or they could be having thyroid problems. Those are some of the most common ones that can be misconstrued. So always make sure that your patient's O2 sats are good and that there's no history of hyperthyroidism. The other thing that means we do want to go ahead and get their vital signs, and we want to make sure that they are stable. They're checking for medical problems. We want to look at their physical appearance and see how are they dealing with this? Are they unkept? Are they dirty? What's going on here? The physical appearance can be a definite indicator to us of their ability to handle their stress. We also want to know what the patient's perception of the stressor is. Maybe the stressor to you wouldn't be significant, but to them is. And so you need to understand that. You need to talk to them about and figure out what is their ability to cope, what kind of support system do they have. Many of our patients don't have a good support system, and that certainly increases the stress. We want to talk to them and find out how they're adhering to their treatment plan, and what is their nonverbal behavior, again, their physical behavior, and their vital signs. Other things that we want to look at is interventions. And so I left this blank because I want you to kind of think about what works for you with stress. What have you seen that has worked with patients that you have worked with in the past? And so some of the things that when I've read up on stress and look at it, some of the main things are exercise. Huge one for lowering our stress and ability to cope with things. Another one is time management, helping our patients and ourselves to prioritize what's really important and what isn't. And more than that, I find that, especially when I'm working with students, is to omit things that are not essential. And I found that with some of my students in the past that have not been successful, it's been the inability to let go of things that they could have. I remember I had one student one time, long time ago, that was failing academically. And so we sat down and looked at her time schedule and looked at her calendar, a weekly calendar, and we slotted in when she was in class, when she was at work, when she was doing other things. And honestly, there was no time for her to study. So, of course, she wasn't going to do well in class because she didn't have the amount of time she needed to have. So we looked at the things that could be omitted, and one of the things was she was involved in something I remember was on a Wednesday evening, and it was something that she was really important to her, but it was non-essential for her at that moment in her life. And I tried to urge her to give that up at least until, nursing school was over, or to minimize it and cut it back, and she just wouldn't, and she did end up failing the course. And so I think sometimes that is hard. I definitely have a problem with this area. I want to do it all, and I want to do it all well. And, sometimes I'm lucky enough to be married to a man that helps me to balance things out and see that some things can be omitted. Other things that we need to do is we need to be proactive. Some of the literature on stress is showing that a proactive stand is the most important part of stress management. And I love proactive nursing interventions. Let's attack a problem before it becomes a problem. And an example of this in our lives is, let's say that our cells are giving us trouble. In fact, after I'd read this one article, I went and got my cell changed. I was having problems getting to my cell was cutting out on me. I was having difficulties with it. So I finally I kept on trying to work with it, and I finally just went in and got an upgrade, and that really made a difference. The problem was I kept on avoiding that because I didn't want to go through that, but in the long run, it removed problems for me. Other things we can do: muscle relaxation, meditation, assertiveness training. God knows I don't need that one, but some of you may need that. Journaling is an excellent way, the literature shows, of being able to process things that are going on in our lives and being able to work through that. Positive social activities, good nutrition, rest, sleep, and of course we always need to think in terms of referrals for ourselves and for our patients. Who can help us to help us through different times of our life? And certainly I've been one that has gone and used a psychologist to help me during certain phases of my life. To help me work through those, because sometimes we just keep on doing the same thing over and over again, and we need somebody else to give us a little insight. So now let's move on to shock. Shock, remember the definition of this is it is a condition, not a disease. The tissues in the body don't receive enough oxygen and nutrients, and so this leads to cellular death, progressing to organ failure, and finally to the whole body failure and death. And this response that we have to the lack of oxygen and tissue perfusion is predictable. There is an adaptive and compensatory responses that are going to happen when this starts to occur, and it is predictable. And because of that, we as nurses need to be able to see the changes that are occurring in our patients so that we can intervene appropriately. And I have read some literature in the past, and they say that we can see some of the changes in these patients 6 hours to 8 hours before it happens. And from my own personal experience, I have seen this to be true, that if we can just look and see these things ahead of time, we can prevent our patients from ending up in these problems in some cases. Sometimes we can't. So let's move on to the next slide. So the types of shocks that we're going to look at today are we're going to look at, I'm just going to list them right now, hypovolemic shock, which is definitely one for periop. Cardiogenic shock is the second one we're going to look at, and that is going to be covered in detail in 281 and 283. Another shock is distributive shock, and the fourth one is obstructive shock. So we'll look at those. Just remember that all of these types of shocks, the major effect of all of these types of shocks is that we are going to see hypotension occurring, and we are going to see anaerobic cellular metabolism. And those two things are going to drive the sequence, and we'll see the sequence occurring as a result. So here is a visual slide to show you the 4 different types of shock that we're going to look at. Going over it again, the hypovolemic shock, the cardiogenic shock, the distributive shock, and the obstructive shock. And remember, all of them, what they have in common is they have hypotension and anaerobic cellular metabolism. So let's look at hypovolemic shock. Hypovolemic shock is the result of losing or a loss of circulating volume. Usually we start seeing this occur when we've had about 15% loss of our blood volume. And the mortality rate for this type of shock is about 10 to 30%. The most common causes for this are hemorrhage and dehydration. And of course the one that we see the most because of periop is our hemorrhage. And so these are the ones that we'll look at. I've seen this one commonly, and most of the time we are able to reverse this one. The second type of shock that we're looking at is cardiogenic shock, and again, I told you this one's going to be covered in 281 and 283. And what ends up happening here is that our patient has the pump no longer is working appropriately. So we have pump failure, so the heart is abnormal. Some of the patients that we see this happening with is our patients that have cardiomyopathy, congestive heart failure, they've had a heart attack, and in fact the MI, or the myocardial infarction, is the most common one of this type of shock, causes of it, and the mortality rate for this particular shock is 50 to 80%. And this makes sense because, you know, unless you can replace that pump, I mean, you can do a lot of things to make that pump work better, but, you know, if the problem is the pump, sometimes we just can't win on this one. Whereas with the hypovolemic shock, if they're bleeding from some site, we can go back into surgery and resolve that. And so that helps us. Some of the cases that I've had problems with is under hypovolemic shock is with our AAAs, our aortic aneurysm, has ruptured and they're bleeding into their abdomen, and we just can't catch up with the blood loss. But most cases we can. The third type is the distributive shock. It's been called many different things in the past. It's been called neurogenic shock, vasogenic shock. But really the reality of it is that it is distributive, and that's because what ends up happening is there is a loss of vascular tone, and what ends up happening is the volume of your blood volume is being distributed, or your fluid volume is being distributed into other areas, predominantly in the interstitial tissue. So so what ends up happening is you end up with a low blood pressure. It makes sense. If your fluid volumes in your intravascular system are being redistributed to some other area for whatever reason, then you are going to drop your blood pressure. So let's look at the different types that we can see here. There is the neurologically induced distributed shock, and this is where the patient vasodilates. And some of the causes that cause us to vasodilate, in one that I've talked about before when we were going over periop, is anesthesia, especially the spinal patient. When we give a patient a spinal anesthesia, we cause vasodilation to a good half to 2/3 of their body. And so now they are vasodilated and they have a relative hypotension. Also, patients that have spinal cord injuries can also end up with this vasodilation. And there are other examples, but I'm listing the ones that we most commonly see. Chemically induced distributive shock is another type that we look at. And this is where the antigen causes a vascular response. And so the most common causes that we see of this happening is anaphylaxis. We see this in sepsis. We see this with whenever there's any kind of capillary leakage, such as burn patients, liver failure, peritonitis, ileus, and also we can also see it with large wounds. And so some of the things that I've seen in this, the most common ones I've seen, is with the anaphylaxis. Certainly when we have our blood transfusions or an antibiotic that the patient responds to with anaphylactic reaction is ones that we commonly see in periop. The sepsis is we see a lot with our patients, and you'll cover that in 283. Burns, I remember when I worked in the ED, we would get patients that had burns, and of course we weren't a burn unit, so we'd stabilize them and transfer them on to Sherman Oaks. But I remember one time a patient had come in, he had set himself on fire and came into us, and he was burned, 3rd-degree burns, all the way from head to toe. And the amount of fluids that he was losing on the peripheral, on his skin, was just amazing. And of course the hypotension was a result of that capillary leakage. He was losing red blood cells and plasma through the damaged capillaries and damaged tissue cells. And you'll be studying burns in 283. Liver failure you'll study in 283 as well. Peritonitis we'll be studying in a couple of weeks, as well as ileus, and so we'll talk about the amount of fluids that then come to those areas because of what's happened on a pathophysiology level. And so then the fluids that go to there, also with pancreatitis is another one, fluids will come to that area, and so then we will end up with a response of losing our blood pressure. And finally, but not last, obstructive shock. And of course this one is covered in 283. What happens here is we have a normal heart, unlike the cardiogenic shock. We have a normal heart, but it cannot pump for some reason. And the most common causes that we see for this is pericarditis and cardiac tamponade. And so these things end up causing a restrictive sac around that normal heart so that the heart cannot beat properly. and so they end up in shock because that heart is not able to pump and maintain a blood pressure that the patient needs. So let's talk about the pathophysiology of shock. Remember, all cells require oxygen and removal of waste products. Homeostasis requires, and so we all want homeostasis, and we want homeostasis in our patients, but what does it entail? It entails that we must have adequate blood flow. So we have to have adequate blood volume. We need to have a functioning pump, so our heart needs to be working. And we need to have a normal blood vessel diameter. And these are the three components that we need to maintain homeostasis. Any alteration in any of these three, if any of them are altered, what will happen is their normal cell function will be disrupted, and we will end up with, once again, there's those words again, hypoxemia, hypoxia, and anaerobic cellular metabolism. And that's going to be the foundation of shock for us. So before we start talking about the different stages of shock, let's talk about some of the indicators that tell us how a patient is doing. And one of the first ones is mean arterial pressure. Mean arterial pressure, or MAP, tells us about tissue and organ perfusion. The mean arterial pressure, the normal range, should be 70 to 100. And probably where you've seen these before is when you go ahead and use the automatic blood pressures on the floor. It'll give you your systolic and your diastolic, and it'll also give you your MAP. And the mean arterial pressure is utilized not much on the floors, on the med-surg floors, but it is definitely used in all of the specialty areas in ICU and ED and OR. It is used to tell us some vital information on how well the body is sustaining itself. And we need at least a MAP, mean arterial pressure, of above 60 to sustain our organs. So how do they determine what a mean arterial pressure is? Well, the reality is we always just hook up our machines and it gives it to us automatically. But if you were doing it the old school way, you would take your diastolic pressure times 2 plus your systolic pressure, and you divide it by 3. So let's do an example of this. Let's say that you have a blood pressure of 120 over 60. So your diastolic pressure is 60, so 60 times 2 is 120. Then you will add in your systolic pressure, which is 120, and so 120 and 120 equals 240. Now you're going to divide the 240 by 3, and that will give you an 80. So there your MAP is, or your mean arterial pressure, is 80, and that is certainly within the normal range. And, you know, when you look at a BP of 120 over 60, that's a normal blood pressure, isn't it? So we all have to look and see what our different blood pressures might be and see if that works. So I would challenge you to sit down right now and let's think about what our blood pressures are. Now, my blood pressure tends to run around 100 over 50. So if we look at that, I'm going to be 50 times 2 is 100, plus 100 equals 200, and divided by 3 is going to be somewhere around 65, 70. I don't have my calculator in front of me, but I'm definitely okay. So you can do some calculations to get yourself better at this, but the reality is we all have that mean arterial pressure on that machine, and we're going to use it. Now, how is mean arterial pressure affected? Well, there are different correlations to the different areas. First off, let's look at volume. When our volume goes down, let's say that I lose X amount of blood during surgery, I can predict that my mean arterial pressure will go down as well, because it is going to go down with blood volume and it's going to go up with blood volume. So as my blood volume goes up, let's say that they give me a blood transfusion, my mean arterial pressure will go up as well. Now, looking at cardiac output, the amount of volume that my heart is putting out with each beat, as my cardiac output goes down, so too does my mean arterial pressure. So as my heart starts faltering and having problems, I can predict that my mean arterial pressure will have problems as well. As my cardiac output starts to increase, I can also predict that my mean arterial pressure will go up. So those go up and down the same. When we look at the vascular bed, though, things are very different. The vascular bed has a converse relationship. The way that our blood vessel responds to changes in our body are very different, opposite of what we'll expect with our mean arterial pressure. So as our vascular bed increases or vasodilates, we are going to see that our mean arterial pressure will drop. As our vascular bed decreases or vasoconstricts, we can expect our mean arterial pressure to come up. And you're going to see that part of the responses, adaptive responses that we're going to see in shock is our vascular bed will change, will vasoconstrict to try and bring that blood pressure up or that mean arterial pressure up. And you can see over on the side here on the right, I have some examples of vasodilation, normal vascular tone, and vasoconstriction. So let's look at changes that can occur in our mean arterial pressure. And I'll kind of say this again as we walk through the stages of shock. So this will kind of be there will be a repeat down the way on some factors. As our mean arterial pressure starts to drop, let's say that it goes down about 5 or 10 points on my mean arterial pressure. So instead of having a mean arterial pressure of 65 that I started with, I now have a mean arterial pressure of 60, maybe 55. So as that drops, what's going to end up happening is the baroreceptors that are located in our aortic arch and our carotids are going to note this change. And so they're going to start shunting blood to the vital areas. As my mean arterial pressure continues to drop, now let's say now I'm down to 10 or 15 drops or even more, we're going to start seeing some anaerobic conditions start to occur because now my body is starting to retain more lactic acid. And so what's going to end up resulting from all the changes that occur is I'm going to end up in metabolic acidosis, and I'm going to end up with some electrolyte imbalances, and we'll talk specifically about what those are. So as these changes start to occur, my mean arterial pressure is dropping, my the anaerobic conditions are increasing. What's going to happen is it's going to result in more and more hypoxia. So I'm going to have the organ perfusion of my organs I'm going to have that loss of oxygenation, and so my body has to do something to compensate. So there's certain adjustments my body's going to do as it perceives that it's not having enough oxygen to the organs. First off, it's going to shunt blood over to the vital organs. And what are our vital organs? They are our heart, our brain, our liver, and our pancreas. And it's going to do that, it's going to have to shunt blood away from organs that can actually tolerate a little bit of hypoxia. Of course, we can't tolerate it forever, but we can tolerate it for a while. And the organs that can tolerate that are our skin, skeletal muscles, stomach, and kidneys. Kind of surprised about the kidneys. We can't last very long, but we will see the blood being shunted away from that. So what ends up happening is we get an accumulative effect of hypoxia, metabolic acidosis, the electrolyte imbalances, and so what will end up happening is we will have it will cause cell and tissue damage. Our heart will not contract. The cardiac contractility will diminish, and we will have cerebral edema occurring where fluid is leaking out of damaged cells. And that's going to cause some cognitive changes. And then finally what will end up happening is we will end up with multiple organ failure. And at that point, full recovery is not possible. Excuse me. So this is kind of a general flow of how things will happen with shock. So now let's look at the specific stages. There are 4 stages of shock. They have different names by different books. The body is trying to compensate at each stage, and it continues to try and compensate until it's no longer able to compensate. But one thing I want you to do is keep your perspective about this. Don't get hung up on what stage the patient is in. Just keep your eyes and ears open for the changes and treat. So we'll try and especially I'm hoping with the time in the simulation lab that we'll be able to give you a little bit more perspective and changes so that you can identify them earlier. Looking at the first stage of shock is called the initial stage. The clinical manifestations that we see at this time is the mean arterial pressure has dropped usually about 5 or 10 points or millimeters per, that mmHg that you have with blood pressures. So we're going to see 5 to 10 point drop on this. The response that we'll see by our body is that our body will try and compensate. Whether we've lost it from volume or from vasodilation or we've lost it from cardiac output dropping, none of these, whatever the reason is, our body's going to try and compensate. So how it will compensate is it will increase your heart rate. So you will see tachycardia. You will also see your respiratory rate increase. And your diastolic blood pressure will increase. So you would probably see with someone like me, if I have 100/50 and I now drop 5 or 10 points, I drop from the 65 to 60, you would see my heart rate increase. Well, my heart rate is actually pretty slow for being a big woman and not as active as I would like to be, but I can run around 60, 62 on my heart rate. So my heart rate would increase maybe up to 70. That might not be significant to you to notice that there's something going on here. That's scary, isn't it? My respiratory rate might increase. Well, you might actually see me going up to 20, 22, 24. And my diastolic will come up as my body tries to make the compensations here. So you might see my heart, that distance between my systolic and my diastolic shortening up a little. This stage of the shock is very easy to miss. So our role as nurses is that you need to always know what your baseline is for your patient. Okay? You need to know where they were before. And you need to be also aware of our high-risk patients. And we'll go over exactly what those high-risk patients are a little farther on. But those type of patients are the ones that we want to be concerned about. So, easy to miss this stage. I'm always telling you guys, don't beat yourselves up too much. This one is maybe a hard one to see ahead. Let's look at the second stage. This is called the non-progressive stage. What a terrible name. I don't know where they come up with these names. Clinical manifestations for this is that we're going to see the mean arterial pressure dropping even more, usually about 10 to 15 points down from baseline. We are going to start seeing some tissue hypoxia to the non-vital organs. So as our body shunts it away, well, we're not going to talk about the response, but we'll see hypoxia. And we'll also see metabolic acidosis, and we'll see hyperkalemia as this hypoxia continues. So with metabolic acidosis, we'll see that pH dropping, and with hyperkalemia, obviously the K will be elevated. Some of the symptoms that we'll see the patient complaining of is they'll complain of thirst, anxiety, they'll start to be restless. Our heart rate will continue to be increasing. Our respiratory rate will be increasing. But one thing we're going to see a little different in this stage is our urine output's going to drop. We're going to see that neural pulse pressure where the systolic blood pressure is dropping and the diastolic blood pressure is elevating. So there will be a smaller, narrower thing that you're going to see here. Now, in the previous stage, I said we'll see the diastolic going up, but the systolic may stay the same, so you may not see as dramatic a change here as you will in the second stage. Also, you will see the O2 stats start to drop, and not significantly. 2 to 5% we might see a patient drop. So we might see them going from 98 to 95. That might not concern you. But some of the things, let's see, next slide. But what is our response? What is our body responding? What are they doing to try and fix this as that map drops more and more? What is our body doing? Well, our body is going to sense that the blood pressure has dropped, and so the kidneys are going to trigger a renin-angiotensin system. So remember, you studying this in fundamentals, how once that system is triggered, we're going to retain urine output, so we won't be urinating as much. Our urine output will drop. We're going to retain sodium and water by absorbing it through our kidneys, and so that's going to help to increase our blood pressure. Also, it's going. Our kidneys are going to, with this renin-angiotensin response, we will see vasoconstriction occurring. In the posterior pituitary, we're going to see some changes as well. We're going to see our body retaining ADH. So this is also, the other name for this is vasopressin, and so that's going to also have more of a vasoconstrictive result. We're going to see water being retained, and the urine is going to drop from this as well. And this vasoconstriction we will see on the skin, because we will be shunting away blood from that area, vasoconstriction, so we'll see some changes in the integumentary here as it gets more cold and clammy. The overall effect of these changes, our body's response in the kidneys and the pituitary, posterior pituitary, is that we're going to see an increase in our fluid volume. Now, it's very important that we see these changes, because this is the stage that we can make major changes. At this point in time, things are still reversible. So when you see your patient showing some of these signs and symptoms, you really need to intervene and make sure that it's caused by something else and not that your patient is going into shock. The third stage of shock is progressive. The progressive stage, the clinical manifestations that we'll see here is your mean arterial pressure continues to drop, now about 20 lower than your baseline. Your vital organs are now getting hypoxic, and all of the symptoms are worsening. You're going to see severe thirst. You're going to see impending doom, confusion, weak, rapid pulse. You'll see pallor, to cyanosis, cool and clammy skin, and your urine output's going to drop to nothing, so you'll see anuria. Your oxygen sats will continue to drop. Now we're talking about 5 to 20% could be dropping. You know your patient is in trouble. You look at these signs and symptoms, and it is obvious there's something wrong with your patient. And this is the third stage of shock. Almost anyone, I think, is going to be able to identify something's wrong with their patient. And so that's why I want you to figure it out at the second stage and not at the third stage. Going on to the next slide, we'll discuss labs. Yes, so some of the signs and symptoms that we'll also see if we were to draw some lab work at this time, we would see our blood gases being definitely impacted. Our pH is going to drop, so we're acidic. We're going to see our PO2 drop, so we are hypoxic. And we're going to see our PCO2 elevate as we retain more carbon dioxide and we get more acidic. I know we have not studied ABGs yet, but we will. Just basically remember that these are the changes that you will see at this stage in the shock. Also, lactic acid is going to be accumulating in our body, so we will see that elevate. And as a result of the acidosis, our body is going to try and compensate, and what will end up happening is we will have hyperkalemia. Not a good thing to have, but our body is trying to compensate for the acidosis. This must be corrected immediately. This stage, which is, in my opinion, very obvious that there's something wrong with this patient, must be corrected immediately or death is imminent. Some books say that within an hour I don't know in my previous experience if I could say it was that long or shorter or longer. It depends on what is the underlying causes of shock and how we intervene. But I do want you to remember, if you don't fix this, we're going to lose this patient. Okay, now let's look at the fourth stage. The fourth stage is refractory. What another name, weird name. Anyways, clinical manifestations of this one is we end up with MODS, which is multiple organ dysfunction syndrome. Ooh, not something we want. This is the result of toxic metabolites and enzymes that are being released in the body due to the hypoxia. What's ending up happening is the dead cells are breaking open and are going to release more metabolites, causing it to make even worse. And so as this occurs, that will trigger microthrombi from occurring, and these will cause more damage, as this will impair perfusion, because now these little micro baby clots are going to be clotting off the vessels and causing more problems for us to be able to perfuse. And this microthrombi starts first in the liver and moves on to the heart, the brain, and the kidney. What ends up happening is our patient will have loss of consciousness, other signs and symptoms. They will have non-palpable pulses. They will be cold and mottled. And at this point, it is too late to stop the progression of damage to the vital organs. You will, at worst, lose your patient. At best, save your patient with permanent organ damage to some of the organs. That would be your best case scenario. But we at this point will lose our patient. The odds, the percentages are about 30 to 100% related to the number of organs that are involved. So this is where we don't want to be. And I have been here before with our patients where you just can't, it wasn't caught soon enough, or it wasn't reversed, or we were dealing with a situation we just couldn't stop the where it was going. So here is a visual one for the different signs and symptoms of shock. For some of you, you will find this to be a good way for you to remember it. Okay, the role of the nurse. So what can we do to prevent this from happening to our patients, or to see it and intervene as quickly as possible? So one of the first things that we look at is prevention. So safety is one way to prevent these things from happening. Certainly preventing any trauma through using appropriate equipment and seat belts and helmets and all these things that we can encourage our patients to use, so that they aren't ending up as one of our trauma patients in the ED and ending up with hypovolemia. Another one is to make sure that our patients are hydrated. Dehydration can be another cause of our hypovolemia, and so we want to make sure that our patients are taking in adequate fluid intake, especially on hot days or if they're exercising. So that's one of the things that we can do as nurses, is prevention. Another thing that we can do is identification of high-risk patients. And so what we want to do is, when we look at our patients, we want to see, is this a patient that could be compromised in some way, and that we would maybe not be able to detect that they are at risk because of various different things. So let's look at some of these risk factors. A patient that has diminished cognition. This makes it very difficult for us to assess whether their restlessness, their confusion, their behavior is due to an underlying medical issue that they have, such as Alzheimer's or a mental illness, whatever, anxiety, versus is it the signs and symptoms of our stages of shock. So this makes it very difficult. It really affects our ability to make a good assessment. So knowing ahead of time what their level of cognition is very important. Another thing that places our patient at high risk is to be MPO. So if our patient is not taking in adequate amounts of fluids, they are going to be compromised on that and at risk for dehydration. So we need to always be thinking about, are they getting fluids in some other way? How are they getting their nutrition? Another risk factor is a lot of our patients are going home very early. We are discharging them right after procedures. So the signs and symptoms may not even be in front of us because they're at home. So that is concerning and a difficult one for us to identify, but certainly if we know our patients are going home early, we need to be watching very carefully to make sure we're seeing that stage 1 or stage 2 signs before we discharge them. Age is another factor. Certainly our young adults are at risk for trauma due to higher risk behaviors, but also our older adults are at risk because all these other things that diminish cognition, and everything. What else did I write here? Older, high risk for all other. I don't know what I meant there, but I think I meant, we have a lot of other issues that are easier for us to not see. I'll clarify that and bring it back to you. Medications can also place our patient at high risk. Aspirin can increase the risk for bleeding. Diuretics can drop our fluid volumes. Antacids can affect our acid-base balance. So these are medications that we need to be looking at because they can distort the picture that we look at. So what are we going to assess? Well, first off, we need a baseline. We need to know what their vital signs are, what their reaction is to pain, what kind of pain they have, what their cognitive ability is, what's their muscle strength. Because remember, as we move into third stage, we're going to lose some muscle strength. So we need to have that. That's why you got to assess them at 7:30 in the morning, and you want to look at those peripheral pulses because we want to see, is there a change? We're going to then remember what the stages are. At certain stages, we'll see certain changes, and so we're going to look for those changes. We're also going to look at the different types of shock that can occur, whether it be obstructive or distributive. We know that there's certain things that are going to be at risk for certain patients. If we have a patient that's septic, we know that they could go into distributive shock. If we have a patient that has pericarditis, we know they could go into obstructive shock, and so on. So we are going to look at those different things and try and look and see if we see those signs and symptoms. We're also going to assess certain parts of certain lab values. And the first one that we're going to look at is the ABGs, arterial blood gases. And you'll see at the bottom picture that is a person doing an arterial blood gas. And an arterial blood gas, in most places, the respiratory therapist does it. It does take a skill. I love doing ABGs. You have to find the artery, and you have to use special equipment, and you have to also have some other information. What's their oxygen that they're taking? What's their temperature? So that they can do calibrate the ABG appropriately. One of the things is that you are getting this from an artery, so afterwards you do have to hold pressure afterwards, and you can hold up to many times 5 minutes to assure that there is not any leakage there. The blood gases, what you'll see is you'll see the pH drop. So we have acidosis. You'll see the O2, PO2 drop. What that means is that PO2 just means it's a partial pressure of the artery and the oxygen levels. So PO2 is the O2 oxygen levels of the blood in the artery, and the PCO2 will elevate as we retain acid and carbon dioxide. And so we will see the PCO2 in the artery. The CO2 in your artery, designated by PCO2, will elevate. The H&H, we can see that drop as our patient is hemorrhaging. But remember, if our patient is dehydrated, it could go up. So it is relative here. Nursing interventions. So what do you want to do besides assessing? We want to monitor our patient. We're going to monitor our patient every 15 minutes. This is when we believe that our patient is either at risk or our patient is compromised or we think we are seeing some signs and symptoms. Other things that we might want to add on here is we might want to add some hemodynamic monitoring. And some of these things that we can do, you'll typically see in the ED, the OR, and the ICU, are putting in a CVP line. And so we want our CVP to be running around 0 to 8. And all these things I'm not going to test you on, but you will be covering them in third and fourth semester. They will put an arterial line in so that they can constantly monitor their blood pressure. And another thing that's good about having an arterial line is you can get your blood gases whenever you need them. A Swan-Ganz or any kind of hemodynamic catheter that can give us readings of the cardiac output, the pulmonary artery pressure, all these sorts of things, the wedge. These are all important things that will tell us how well they're doing, how well the heart's functioning, how well the cardiac output is, how good the blood volumes are. And so we will add in these different types of catheters and monitors that will help us. No test questions specifically on that. Intake and output will be another thing that we will watch because certainly we need to see how much they're taking in, but we also need to watch that urea that can happen, that urine output that can drop. They should have a Foley catheter in place. You should be monitoring their urine output every hour. Other things to consider besides that is ECG is another one that we need to be watching how their heart is responding. We can see that tachycardia, but we can also see the effects of any the elevated potassium might be causing us some arrhythmias. And also oxygen, O2 sats would be another one because we know as we move through the different stages that O2 can drop. Infusion therapy, we want to improve their fluid volumes. Typically, I would just say without a shadow of doubt that this patient should have 2 IVs, one that we can give fluids through and another one that we can give blood to. We are going to at first start with increasing the fluid rate, but remember if we give too much fluids, it can also stimulate the inflammatory response. So we have to think at some point we need to probably add in some blood here. Crystalloids are our fluid choice. We typically will hang up normal saline on one side and Ringer's lactate on the other. Ringer's lactate, we've come to find out, is the best balanced one, but the problem is we also know we can't give blood with it. So we want to go ahead and have the saline on the other side so we can throw up our blood products. Colloids, oh, I really am messing up that one. Colloids are a fluid that will expand the fluid volume. Some of the typical ones that we see are plasminate, spelled Plasmanate. Hespan is one of those type of products as two. Products of a colloid, Hespan. These are ones that we hang up to try and pump up that blood volume. But at some point we really do have to think about blood products. If we can get whole blood, that's great because that gives us the volume and the red blood cells, but typically we're going to be going with our packed red blood cells to give that patient the blood volume that they need because especially if the cause is hemorrhaging. And most of the time when I'm talking about this, I am talking about our hypovolemic shock. Other things that we can do, we want to give them oxygen because we know that they're getting hypoxic and we want to improve the oxygenation of their cells. We want to put them in shock position because this helps to improve perfusion, perfusion to their vital cells. And of course, this is where you need to remember, not Trendelenburg because that dumps them right on their head. We want them in a modified Trendelenburg where their head is slightly up and their feet are up. Okay. Another thing that we need to consider is that is specific things that will help our patient based on what kind of shock they have and what the cause is. And certainly as a perioperative course, one of the first things that we consider is surgery. We would consider taking our patient in to repair or revise to try and stop whatever's happening. And like I mentioned earlier, an aortic aneurysm there's no way to resolve that but to take them into surgery and try and fix that aneurysm that has ruptured, because that patient is going to die. Other things that we can do besides surgery for our patients is medications. Vasoconstrictors are a good choice for our patient. It will help our mean arterial pressure. It also increase our O2 perfusion. Some of the drugs that we use in this category are dopamine and Levophed. The problem is we have to worry about these drugs is that they cause severe vasoconstriction, and so they lose, they have perfusion that is very compromised in the peripheral tissue. And we used to use dopamine for our children. We got a lot of drowning victims at Children's Hospital in that season, May, June, July. Those little kids, and I remember one kid distinctively that had ridden his Hot Wheels into the pool, and the parents found him too late. They were able to revive him and bring him to Children's, and we had him in the ICU. But he was we were losing him, and we were trying to help him with giving him vasoconstrictors to try and improve his blood pressure and perfusion. But his hands and his feet were turning absolutely purple and blue. And we did end up losing that child. But if we hadn't lost him, we would. And there were other children that we did save. Sometimes we ended up having to amputate those hands and feet. So you really need to be thinking about the amount of vasoconstriction. And usually we are thinking about that. As we are increasing that vasoconstrictor for that child, we knew the risks that we were taking, but we were trying to save his life. Another type of medication that we can use is the inotropic agents. These will stimulate your beta receptors, so they're going to increase our epinephrine and our norepinephrine, and that helps our blood pressure and our heart rate. And dobutamine is one of the drugs of choice in this category. Another thing that we want to think about is, what about the myocardial perfusion? And this is very important if we're concerned about the cardiac contractility and the heart function, especially with our patients that have had an MI. But it's also true that as they move through the stages of shock, and that the cardiac contractility is going to diminish. And so we want to think at some of the sort of drugs that might help perfusion, and nipride is one of those drugs. What it does is it dilates the coronary arteries, but not the systemic ones, although sometimes it does. But only when we get to really high doses. And so it'll help the heart function better, give it more perfusion. And so that might be a consideration, especially for our patients with MIs. Okay, well, I think that's the end of this lecture. Now what we're going to do is, I hope that you go over this and really try and put it in your brain and have some thoughts of what you're thinking, and then we'll come into Skills Lab on Tuesday and hopefully can illustrate it so that it becomes more meaningful for you. Thank you, and have a great day or evening, whichever time you're watching this, and I'll see you next week.